Hello students, good morning all. This is Dr. Nandhini working as Associate Professor from Department of Pediatric and Preventive Dentistry, VMSDC, VMRFDU. Today I am going to talk about the topic Ped and Fissure Sealants. So talking about the introduction, despite the dramatic reduction in caries in fluoridated community, the disease still continued to occur during childhood and there is a sustained caries susceptibility of pits and fissures. According to Ash, pit is defined as a small pinpoint depression located at the junction of the developmental grooves or at the terminals of these grooves. According to Orbans, fissure is defined as deep clefts between the adjoining cusps. According to Simonson, the term ped and fissure sealant is a material that is introduced into deep pits and fissures of caries susceptible teeth, thus forming a micromechanically bonded protective layer cutting access to caries producing bacteria from the source of nutrients. So next we are going to talk about the history. In 1905, Miller used silver nitrate. Prophylactic odontomy in 1992 Hyatt advocated filling of the fissures with silver or copper oxyphosphate cement as soon as the tooth erupted in the oral cavity. Later, when they are fully into the mouth, that is fully erupted into the oral cavity, preparing a small occlusal cavity and filling the deep pits and fissures with amalgam. Gwinnett and Bunoker in the year 1965 used an approximate of 50% phosphoric acid solution etched enamel and porosity that resulted and that was penetrated by cyanoacrylate. Bischema was introduced by Bowen in the year 1965 at the National Bureau of Standard from adduct of bisphenol A and glycidyl methacrylate. So next is about the types and morphology of pits and fissures. It usually varies from one to the other. The premolars have got prominent primary fissure with 3 or 4 pits, whereas molars have got 10 separate pits and that may be present in primary, secondary and supplemental fissures. So now we will be seeing about why there is a need for us to go for sealants. So here in this picture you can see the toothbrush which has got bristle, and that is the width of the toothbrush is very deep to penetrate into the deep pits and fissures. So there it acts as a source for microflora which is not cleansable for a very long time period. Next is about the morphology in depth in a scanning electron microscope of what does the deep pits and fissures contain. The fissures contain an organic plug composed of reduced enamel epithelium, microorganisms forming dental plaque and oral debris. Moreover, the fissure provides a niche for the plaque accumulation. This in turn, if it is not clean, might lead to a big cavity and caries. So, caries progression in pit and fissures. First, the enamel rods flare laterally in bottom of pits and fissures. As a result of this, caries occur. It follows the direction of the enamel rods and there is a triangular lesion with base towards the dentino-enamel junction. Greater number of dentinal tubules are involved in this, thereby ped and fissure caries involve a large occlusal surfaces. This in turn results in a greater cavitation than the proximal lesions. Next is about the AAPD recommendations for the use of ped and fissure sealants. Sealants should be placed into deep pits and fissures of teeth based upon the patient's caries risk and not on the patient's age or the time lapsed since tooth eruption. Sealants should be placed on surfaces judged to be at high risk or surfaces that already exhibit incipient lesions to inhibit the lesion progression. Follow-up care as with all dental treatment is recommended. So, sealant placement should include cleaning of the deep pits and fissures without removal of any acceptable enamel. Some circumferences may indicate use of a minimal enameloplasty technique also. A low viscosity hydrophilic material bonding layer as part of or under the actual sealants is recommended for long-term retention and effectiveness. GIC materials can also be used as traditional sealants. So next is about the European Academy of Pediatric Dentistry, and they have recommended some guidelines for the use of ped and fissure sealants. First, patient and tooth selection should be based on the following. Children and young people with medical, physical or intellectual impairment should include the buccal fissures of permanent molars. Children and young people with no signs of caries activity, only deeply fissured, extremely plaque retaining fissures and thus potentially susceptible surfaces should also be considered for sealing, and this is given by Leek et al. In the year 1997. So next is about the types of ped and fissure sealants. According to the chemical structures and monomers used, the first kind is methyl methacrylate, where we call it as MMA, and next is TEG-DM, that is triethylene glycol dimethacrylate, and bisphenol dimethacrylate. Next is the bisgema, that is reaction product of bisphenol A and glycidyl methacrylate, ESPE monomer, and propyl methacrylate urethane. Next, we are going to see about the sealants based on generation. Based on generation, there are 4 types of sealants, wherein the first generation sealants is polymerized with the UV light of 356 mu meter. Here, there is excessive absorption and incomplete polymerization at its depth. So, next came the second generation of sealants. They are self-cured or chemical cure resin based on accelerated catalyst system. And the third generation includes the light cured with the visible light wavelength of 430 to 490 mu meter. The fourth generation are fluoride releasing sealants. Based on the filler content, it's classified as either filled or unfilled resins. The filled sealants are resistant to wear, whereas the unfilled ones have got a better flow and more retention but abrade very rapidly. Based on the curing, it's classified as autopolymerizing or the light cure type of sealants with a different wavelength of depth penetration thing. And the next is based on the color. On this, it's classified as clear, tinted or colored kind of sealants. Here in this picture, you can see the color sealants that is used. And this is a video showing how the sealants used. This is the small picture of a brief thing, the resin sealants that is used, wherein you seal the deep pits and fissures and light cure it with a visible light wavelength, thereby sealing the deep pits and fissures that is present in the oral cavity. So let's see the steps that is involved in the preparation of ped and fissure sealants. The first includes cleansing the tooth surface. This is done using a Prophy cup and pumice with water. Any non-fluoride paste which is not oil based can be used for this purpose. And this is a picture showing how the pumice is used to clean the deep pits and fissures before the placement of sealants. And the clinical technique for the placement of ped and fissure sealants, first step is isolation. It needs a perfect isolation so that the retention of the sealants will not be hampered. Isolation can be done with the help of a rubber dam or cotton rolls. This procedure is very technique sensitive, so moisture control is essential to get a optimum bond strength. Silverstone in the year 1984 concluded that salivary contamination allows rapid precipitation of glycoprotein into etched surface, decreasing the bond strength. Even 1 second of exposure to saliva can form a protein layer resistant to 30 seconds of vigorous irrigation. Hitt in the year 1992, Fiegel in 1979 postulated that applying halogenated bonding agent after etching can increase the bond strength. And the step 2 was tooth preparation, wherein Brocklehurst in 1992 suggested that Air abrasion with aluminum oxide particles is best method of cleaning, and it results in improved retention of wetting the resins, more number of resin tag formation. Garcia Gaude et al. In the year 1994, Zervo et al. And 2000 year recommends enameloplasty as it increases the surface area and decreases the micro leakage. A prophylaxis before sealing is not essential, although tooth preparation can be useful. In looking at micro leakage of sealants after conventional burr and air preparation of pits and fissures, superior results were obtained when the tooth surfaces were prepared with burr, while conventionally clean and air abraded surfaces yield similar results. And this was concluded by Hattie Bowick Kaufman in the year 1998. And next is etching time, which is a very critical procedure for this placement of sealants. This etching time is more for primary teeth than permanent, and this was the earlier concept. But Dugal et al. In the year 1997 used different etching timing of 15, 13, 45 and 60 seconds and concluded that there is no difference in retention of sealants using different etching times and etching patterns. So, Tandon et al. Again in the year 1989 have proposed an etching time of 15 seconds to be sufficient for primary teeth. And step 3 is acid etching of tooth surfaces. Apply the etching agent, that is 37% of phosphoric acid, to the tooth surface using a fine brush or a mini sponge according to manufacturer's recommendations. Bunakur initially used 80% of phosphoric acid, but nowadays 37% of phosphoric acid is recommended. Rub the etchant applicator over the tooth surface including 2 to 3 mm of cuspal inclines. So, there are scientific basis for acid etching that is given by Silverstone in the year 1975. Acid etching on tooth surface enamel has shown to produce a degree of porosity. First, a narrow zone of enamel is removed by etching wherein plaque and pellicles are dissolved. Here, fully reacted inert mineral crystals in the surface of the enamel are also removed, resulting in more reactive surface, increase in surface area and decrease in surface tension. The first zone is 10 μm in depth. The second zone is the qualitative porous zone, which is 20 μm in depth. Because of the porosities created, this zone may be distinguished qualitatively from enamel by polarized light microscopy. And the third zone is the quantitative porous zone with small porosities, and that is 20 μm in depth. So, next is step 4, wherein rinsing and drying the edged tooth surfaces. Rinse the edged tooth surfaces with air water spray for a time of 30 seconds. This removes the etching agent and the reaction produces from etched enamel surfaces. Next is step 5, that is application of bonding agent. Application of halogenated bonding agent after etching displaces saliva from enamel, thereby improving more sealant surface and increases the bond strength. And next is step 6, that is application of sealant. Apply the material and allow it to flow into the deep pits and fissures. In mandibular teeth, apply the sealant distally and allow it to flow mesially with the converse for the maxillary arch. Allow the sealant to flow in each pits and fissures to avoid incorporating air into the material and void surfaces, that is to avoid void. Next is the curing of sealants according to the manufacturer's recommendations. Hicks et al. In the year 2000 found that argon laser curing of sealant material may enhance the caries resistance. So, this picture in turn is a brief thing of how do you place sealants into the patient's oral cavity. The tooth surface first is cleaned, conditioned and air dried, and sealant is dropped into the surface and flows into the position filling all the deep pits and fissures. Here the sealant sticks into the tooth surface and is hardened under a blue light for a light tooth sealants. The tooth is then sealed, giving full protection so that the deep pits and fissures are completely protected out of caries. This is for a recently used kind of sealants. So a report by Nuva Seal, the first sealant marketed, noted that 84% caries decrease over 1 year and 53% 2 years after the application, and this was reported by Alvizalo in the year 1977. So next is fluoride used along with sealants. In the evaluation after 4 years, the combined use of fluoride and dental sealants, the overall proportion of sealants retained on occlusal surfaces of first molars after an average of 2 years is 92%, reported by Selvitz in 1995. This study suggests that pit and fissure sealants confer additional caries preventive benefits beyond those fluoride therapy alone. In a 2-year clinical evaluation, Carlson in 1997 of a fluoride containing fissure sealant, HelioSeal F, in young school children at high risk for caries, a total of 431 fissure sealants were placed at baseline. Complete retention was found in 77% during the study period, while using 22% were partially lost. 6 sealants of 1% were completely lost. Hicks MJ in the year 2000 did an in vitro analysis of fluoride release by pit and fissure sealant and showed that sealant may provide additional protection against caries formation in cuspal incline, enamel and smooth surfaces adjacent to sealed pits and fissures. Sealant may act as a fluoride reservoir with long-term release of fluoride into immediately adjacent oral environment. So next is the glass ionomers, which are recently used as sealants. The logical assumption that a material that releases fluoride such as glass ionomer cement would provide an added benefit to the retentive blocking of the fissure by a sealant. Study by Mejar and Mujor resulted in 61% of glass ionomer sealants which were lost within 6 to 12 months and 84% after 30 to 36 months. The clinical evaluation of the resin-based sealants showed an average complete retention rate of 90% after 4.55 years. Next is sealant over caries. Here, Handelman in the year 1972 was the first to report on the interesting aspect of application of sealant over caries. In this 2-year analysis, Handelman noted that preliminary clinical and radiographic findings suggest that there was no progression of caries lesions. Going et al. Noticed that a limited number of cultivatable organisms persist on some lesions, but their numbers are few and they do not appear capable of continuing the destruction of tooth structure. Eva Mertz, Fairhurst and so many co-workers carried out landmark study of the effects of sealing caries. Mertz-Fairhurst's 10-year study evaluated bonded and sealed composite restorations placed directly over frank cavitated lesions extending into dentine versus sealed conservative amalgam restorations and conventional unsealed amalgam restorations. These results indicate that both types of sealed restorations exhibit superior clinical performance and longevity compared with unsealed amalgam restorations. So next we are going to talk about the cost effectiveness of sealants. Most of the people might think like sealants are used before the onset of caries, so it is an extra asset wherein the patient has to give or pay for a non-caries tooth lesion. So there is a lot of debates arising that whether there is a need for you to use a sealant or not to use, like to restore only after the decay is erupted into the oral cavity. For this, at a 10-year point of a 15-year study, it was found that it is 1.6 times as costly to restore the caries lesions in the first permanent molar in an unsealed group of 5 to 10-year-old children living in a fluoridated area than it is to prevent with a single application of Ped and Fissure sealants, the greater number of lesions observed if Ped and Fissure sealants is not utilized. And this was proved by Simonson RJ in the year 1982. So, for the underuse of sealants, it has been documented for decades that sealants are safe, effective and underused. The latest data available indicates that in the United States, only 15% of the children within the age groups of 4 to 17 have dental sealant application. This was reported by Cherry Peppers G in the year 1995. Next is about the use of an intermediate bonding layer. Fiegel came up with the novel concept of hydrophilic bonding materials that contain water may, when applied under a sealant, minimize the bond strength, and this is normally lost when a sealant is applied in a moist environment. Bonding agent under a sealant on wet contamination yielded bond strength equal to the bond strength obtained when the sealant was bonded directly to clean etch enamel. So, moving on to the new development and projections in the use of sealants, shorter etching times than the originally proposed 60 seconds for permanent enamel and 120 seconds for primary enamel times as short as 15 seconds have been found to be as just effective as the longer etching patterns and the time used for it. Sol et al. Also looked at cleaning methods and found that use of a sodium bicarbonate air polishing system resulted in a statistically significant higher retention of sealant. Irinoda et al. Showed that a low viscosity sealant penetrates better and forms a resin impregnated layer with enamel, whereas the higher viscosity sealants tested did not penetrate enough to ensure that the acid etched enamel was infiltrated sufficiently by the sealant to ensure a good marginal seal. Next is about the use of lasers in the field of Ped and Fissure sealants. Here, argon laser polymerization provides further caries protection against a cariogenic challenge over that afforded by fluoride releasing sealants. In the year 1993 study, Hicks and co-workers found that argon laser curing of sealant may enhance the caries resistance of the enamel, forming the enamel resin interface and result in reduction in caries formation adjacent to sealants. Next is the polishing before sealant application. Always polishing before sealant application enhance the bond strength of sealants compared to traditional polishing. Deeper penetration of sealant resin into the enamel surface. Although air polishing prior to sealing teeth was examined, the effects of air polishing on fissure sealant material was not mentioned in the literature review by Gutman et al. In 1998. Pelka et al. In 2010 used air polishing of fissure sealants resulted in substance loss, producing more surface damage with sodium bicarbonate powder than glycine powder air polishing method. And this picture represents a small concised one of how to do a Ped and Fissure sealant. First, do a thorough oral prophylaxis, and it's mandatory to isolate it with help of rubber dam or cotton rolls to prevent moisture contamination. Wash and dry the tooth surface, etch it with 37% of phosphoric acid and wash and dry to get a dull frosted appearance over the deep pits and fissures. Apply the sealants and light cure. Based on this, it can be either a light cure or a self-cured kind of sealants, which was previously mentioned in the classification and the method of use. So, based on the concepts of prevention, I would better suggest that rather than drilling and filling the tooth surfaces, it's better to go for sealing and healing the tooth surfaces for a better benefit and a good preventive aspect of dentistry. Thank you all for listening.